Hi, everyone. I'm excited to welcome you to the second of three webinars about clinical practice and research related to the COVID-19 pandemic and its aftermath, sponsored by UCSF and the San Francisco Bay Collaborative Research Network. My name is Michael Potter, and I'm a professor in the Department of Family and Community Medicine and director of SFBayCRN. SFBayCRN is UCSF's primary care practice-based research network supported by UCSF's Clinical and Translational Science Institute. In addition to educational meetings such as this webinar, we also, through our website, provide consultations to facilitate the development of practice-based research partnerships. Please reach out to us if you're interested in learning more about our network. And now I want to thank you all for joining us today to hear a presentation by Dr. Lekshmi Santhosh on the topic of UCSF's post-COVID optimal clinic, lessons learned and opportunities to improve community-based recognition and treatment. Dr. Santhosh is an attending physician in adult pulmonary and critical care medicine at UCSF's Helen Diller Medical Center at Parnassus Heights, and she sees outpatients in UCSF's pulmonary faculty practice. In this role, she's cared for acutely ill patients with COVID-19 and was among the first to recognize and address the need for ongoing clinical care for patients with persistent symptoms long after being infected. She is the founder and medical director of the multidisciplinary Long COVID Optimal Clinic at UCSF Health. And in this role, she's gained tremendous experience and insights that can inform our care for post-COVID patients in primary care, including areas that are ripe for further research. I'll turn it over to Dr. Santhosh in a moment, but I also want to introduce Dr. Carlos Guerra Sanchez, who is a pediatric infectious disease specialist and clinical leader at the Family Healthcare Network. FHCN is one of California's largest federally qualified health centers, serving over 100,000 patients in Fresno, Kings, and Tulare counties. And FHCN has been at the center of providing medical and social services for ethnically diverse, low-income, and often uninsured patients in the Central Valley, both before and during the pandemic. Dr. Guerra Sanchez also serves as a board member of Here with Community, a federally funded program intended to develop opportunities for COVID-19 research collaboration between UCSF, Northern California's community health centers, and their community stakeholders. Dr. Guerra Sanchez and I will moderate a conversation with Dr. Santhosh after her lecture, so please post your comments and questions for us in the Q&A section during the lecture. Also, we ask at the end of today's session that you complete the very brief survey that will be automatically sent to you when you log off the webinar. This will really help us to know what you thought of the webinar and to plan for future activities. And finally, I want to offer a warm welcome to Dr. Santhosh.
Thank you so much, Dr. Potter, for the very kind introduction. I'm really honored to be with you today and share some lessons that we've learned and also seek your ideas, your input, your collaboration moving forward. I don't have any conflicts of interest to disclose. Before we go too much forward, and get into the nitty-gritty of long COVID, I just wanted to take a moment to acknowledge just the tremendous toll that this pandemic has had on all of us and our patients and our communities in the past 2 to 3 years now. We're approaching the near 1 million US deaths mark, which is just unimaginable. I still have my newspaper when we had the 100,000 death mark with names from my hometown. And now that we're at 1 million deaths is truly unfathomable. And I thank you all for being here and honoring our patients and our families and our communities and working hard together to try to end this pandemic. What's clear over time is that we know that COVID is a multi-organ system infection acutely. It's not just about the lungs, even though, of course, they are my favorite organ as a pulmonologist, but it also affects, the cardiovascular system with myocarditis and arrhythmias, the GI system, the kidney system, immune system, of course, mental health and neurological symptoms, which we'll talk more about, and even fertility acutely. And then we know now that longer term outcomes similarly are affecting multiple organ systems, again, from head to toe, from neurological symptoms to mental health symptoms to chronic cardiac issues, chronic lung issues, and neuromuscular issues. And also, in addition, there seems to be a subphenotype of patients called the long haulers, or long hauler patients, or patients with long COVID. There's clearly this subset of patients who have a course that waxes and wanes, kind of symptoms get better or worse. There's flares, there's a lot of fatigue, particularly post-exertionally, paresthesias, cognitive impairment or brain fog, dyspnea, and palpitations. And so not all patients will have symptoms in all of these organ systems, but many have fallen into the kind of this phenotype. And we also know that patients are not just hospitalized, right? Many of our patients who've been affected were never hospitalized and are seeking care in the outpatient setting, whereas some were hospitalized in the ward, some were sick to go to the ICU, and some traversed multiple of these contexts. And the other thing to know, of course, is that these disparities have affected access to COVID-19 care and treatment at every step of the way, unfortunately. So because of our society and racism, classism, and social stratification in our socio-political context, these disparities emerge at multiple points, whether that's in exposure to who gets COVID, essential workers, people taking public transport or living in large multifamily housing, care delivery, it's affected, bias in the hospital, discharge care, and post-discharge care. So we have to be mindful of these barriers and, again, work extra hard to be mindful of the barriers and work to dismantle them together. I think the other hard thing, there's so many hard things about long COVID, is that symptoms do not necessarily correlate with organ dysfunction. And what I mean by that is many of you have seen patients or have had family members where all of the tests come back normal, normal heart testing, normal lung testing, but symptoms still persist. And I think the other puzzle of long COVID is that you might have patients who are critically ill in the intensive care unit. They may not have too bad persistent symptoms when they recover. And on the other hand, you could have that, marathoner, runner, working parent who is doing fine and never hospitalized with just a mild infection, who actually has persistent symptoms for weeks to months afterwards. So this is another puzzle in this condition that we're seeking answers for. And so we have a lot to cover today. Dr. Potter gave me a big charge, but I'll try to take you through kind of symptoms in pulmonary system, physical health, cognitive health, and mental health affecting patients with long COVID, thinking about where is the ongoing research in the Bay Area, and thinking about, how do you think about starting a long COVID clinic? Is it cost effective? Why would you do such a thing, et cetera? So of course, let's start with a real life patient. So this is a patient who I saw in the ICU and I followed her in clinic afterwards. She's an 83-year-old woman. She's primarily Spanish speaking, and she was admitted to the ICU for COVID pneumonia. She has diabetes, hypertension, and hearing loss, and lives with her daughter, who's her power of attorney. And she was first discharged to a rehab and then eventually to a skilled nursing facility, and eventually went home, recovered home. She was on high flow nasal cannula throughout. She was never intubated, fortunately. And she still remains breathless, anxious, and socially isolated for weeks after hospitalization. And I think this is a common patient experience that we've seen in COVID. So first off, kind of what is long COVID? How do we define it? For really almost 1.5 years, we didn't have a consensus definition. So a lot of the studies around long COVID, from prevalence to symptoms, et cetera, for the first 1.5 years of the pandemic, were hampered by not having a consensus definition. In June of last year, the CDC came out with this definition. And I love a couple of things about the definition. One is they say objective lab or imaging findings should not be the only measure of a patient's well-being. And lack of lab or imaging findings does not invalidate patients' symptoms. So what they're saying is, believe your patients. Even if they have normal testing so far, they are still having symptoms. They also say good advice, which is that there is no one long COVID cure or silver bullet. And if you see somebody saying that they have it, it's too good to be true, it probably is, right? And because of that, what the CDC advises, which I think is very helpful for all of us frontline clinicians, is to think about what is the most bothersome symptom that a patient is experiencing and focus on that. So is the headache the worst cause? Dysautonomia, shortness of breath, and try to focus on treating that because we have a lot of evidence for that while we do ongoing research to find out, what is the underlying mechanism. And, this is an evolving target. There's a lot of research going on. There's a lot of uncertainty. And so this research is ever evolving. A lot of people have been asking me about, what about Paxlovid, the new antiviral? Does that help long COVID symptoms? Because there's a lot of anecdotal data that in some patients it has helped them. And again, there's ongoing trials that we need to see how these new therapies are impacting. And I think the tough part that I hope to share with you today is that there is no one long COVID experience. There are so many different types of patients and experiences that one size fits all really isn't possible with such a vast and heterogeneous condition. WHO also, again, last year came out with this definition, which is nice. They say it can occur with a history of probable or confirmed COVID, usually 3 months after the onset of COVID, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. I really like that part of the definition. We'll come back to that point, which is basically that all that long hauls is not COVID. And what I mean by that is that we have to put on our broad thinking caps and make sure that patients are not having other conditions that are not COVID. I personally have seen patients with metastatic lung cancer, metastatic prostate cancer, metastatic colon cancer, ulcerative colitis, postpartum depression, sarcoidosis, hypersensitivity pneumonitis. These are just my personal patients where I diagnosed them with these things and it was not COVID, but either the patient and or the clinician said, oh, it's just your long COVID symptoms. So we have to always keep an open mind and think about, could this be something else? Because now, again, this is affecting millions of people. We have to also consider that we're detecting some other conditions that may be true and unrelated, that may be related. There's a lot we have to learn. So what do we know so far about illness recovery? This is one of the earliest long COVID papers that came out of Italy early in the pandemic, April. And this paper holds up really nicely today. And it talks about what symptoms are persisting in patients after follow-up for COVID-19. You see fatigue, shortness of breath, joint pain, and chest pain are the most common. And you see at the bottom of the list things like diarrhea, myalgia, vertigo, persistent sore throat. And I like this graphic because it shows you that if you are hearing about a lot of symptoms on the bottom side of this graph, again, think twice. Could this really be COVID? It is in a small proportion of patients, but also could we be missing some other diagnoses? So that study has been reproduced multiple times. So here's some newer studies from JAMA in 2021. Here's a nice kind of review paper from 2021, again, showing these multi-organ system complaints and symptoms that I've shared with you. So let's focus on pulmonary for a brief bit. So one of the things that's interesting that I mentioned is that people have a lot of different kinds of pulmonary symptoms. Some, like in column A, will have a little bit of ground glass. Some, like in column B, not too bad. Column C, significant fibrosis and lung scarring. And column D, a little bit of fibrosis remaining. And you have to ask again, what was their initial severity of illness? How bad was it initially to help us correlate? And so usually the more severe the initial illness, the more persistent the lung abnormalities are on imaging. But like I mentioned, imaging doesn't tell the whole story. What about PFTs? PFTs are not perfect as well. So this is a classic paper pre-COVID looking at just ARDS, acute respiratory distress syndrome, from all causes. And they found that people can have abnormal PFTs, particularly the diffusion, for up to 2 years after ARDS. And we're seeing this in COVID as well, that people can have abnormal PFTs for months, if not years. I love this slide from my colleague, Dr. Schwab, who runs the long COVID clinic at UCLA. And she talks about how there's a broad differential and common things being common. A lot of people have had COVID kind of unmask some reactive airway disease. So basically people will say, doc, I never had asthma before in my life. And now I'm acting, like asthmatic. I'm wheezing, I'm coughing with any minor cold like I have right now. Sorry about that. And so think about post-viral reactive airway disease as a very common cause of persistent dyspnea. Deconditioning is huge. So remember, we say that for every day of hospitalization, you lose muscle mass and you have to come back from that. And it takes about a week to recover, is how I counsel patients, particularly our elderly patients. And I will say, even as a younger, relatively active, relatively healthy person, when I myself, unfortunately, had Omicron in January, the profound, the isolation, the profound fatigue, the deconditioning that you get, even with just a short period of isolation, is quite profound to recover from. We'll talk more about deconditioning in a second. Organizing pneumonia, so that's a steroid responsive process. That is quite rare, about 1% of patients post-COVID. So we really should not be prescribing lots and lots of steroids for patients with persistent dyspnea, because it won't help unless you see organizing pneumonia, steroid responsive organizing pneumonia on a chest CT. So that's quite rare, kind of less than 1%. Similarly with post-ARDS fibrosis, that's quite rare. And we really usually see that in people who, again, had really serious illness up front, who were intubated, et cetera. And then pulmonary vascular disease, PE or DVT, that's uncommon, but more high risk early on in hospitalization, particularly. There are some new studies showing that perhaps the abnormal anticoagulation in COVID can persist for up to a year afterwards or even longer. There's this new Nature paper talking about increased cardiac events for up to a year afterwards. So the anticoagulation, this clotting and bleeding diathesis that we see in COVID, that's clearly dysregulated, and there's a lot that we're still learning. Other things to think about is just acid reflux associated cough, pleuritis, neuromuscular disease, vocal cord dysfunction, and tracheal stenosis or tracheomalacia, but keep the differential quite broad. What do? We tend to, because I told you that many patients will actually recover with conservative management, we don't do PFTs up front until the 3-month mark. So if people are still symptomatic at the 3-month mark, that's when we do PFTs. And I really like to include a 6-minute walk test. And you can just do that in the office, even if you don't have a PFT lab, a 3-minute walk even. And the reason I like the walk test is because most patients with persistent symptoms have some sort of post-COVID dysautonomia. And many times patients will get very tachycardic with exertion. Sometimes they'll have orthostatic vital signs. And often when patients get this exertional tachycardia and palpitations, often people interpret that body sensation as dyspnea. So a 6-minute walk or even a 3-minute walk in your clinic, in your office, can actually show you, are they desaturating with exercise, or are they getting quite profoundly tachycardic, and that's causing them to have palpitations and dyspnea? Because you would treat those differently, right? If your PFTs, over 3 months out are abnormal, then I might consider a CT chest and an echo. Labs are helpful because a lot of patients are walking around with, again, other health conditions. Many people avoided seeking primary care, right? Healthcare maintenance during the pandemic for 1 to 2 years. So that CB screen, I've picked up a lot of anemia, and like I mentioned, even multiple malignancies with just a screening CBC. ESR and CRP are not that helpful to me, so I would recommend against ordering them. They're often either low-grade elevated, you don't know what to do, or they're normal. Thyroid is helpful for fatigue workup. I've seen a lot of undiagnosed hypothyroidism, and then a CK can be helpful if you have a lot of myositis type symptoms. So speaking of CK and myositis, what about the physical symptoms? So our patient, she was very deconditioned and weak, and she was quite elderly and deconditioned and frail at baseline. So she had severe post-exertional fatigue. Again, we know from the pre-COVID literature that up to 2/3 of patients in ICUs with ARDS have had fatigue over 1 year after discharge. So fatigue is a very common symptom. Again, not all COVID patients have been in the ICU, right? So even in patients who are not hospitalized with mild symptoms, many have this overlap with myalgic encephalitis, chronic fatigue syndrome as well, where they're having significant fatigue even though they were not hospitalized. And again, our elder adults, our geriatric population, we have to pay special attention to our elders because they're already at risk of delirium, PTSD, and we have to assess to them what matters, what are their goals of care, look for de-prescribing medicines. How many times have you seen a patient, especially an elderly patient who was hospitalized, who's still on steroids that they didn't need to be on, who's still on DVT prophylaxis, who's still on antipsychotics that they didn't need when they're in the hospital, or even that PPI that they didn't need. So I do a lot of de-prescribing at our clinic. And then thinking about their mobility and mentation and seeing, pulmonary rehab is now covered by Medicare. for many patients with persistent symptoms. So seeing, can I refer them to pulmonary rehab or physical therapy, or even give them some exercises to try at home. And speaking of physical therapy, the National Association of Physical Therapists put together this great document. And this figure I come to time and time again. I show it to patients in my office or draw it out for them. And I guess in contrast to the traditional medical model of, push yourself every single day, go up and up and up. In contrast, because many patients have that post-exertional fatigue, you're asking them to be so gradual and focus on pacing themselves and resting. And so if you have a load, you want to make sure that the patient is really adapted to that load before increasing activity. So I tell patients, what is your floor? What is the least amount of activity that doesn't take the wind out of you? Focus on mastering that first, whether that's 2 minutes of walking or 10 minutes of walking, and really master that for like a week or two before you increase that ever so gradually to 11 minutes to 12 minutes, not the walk more and more and more every single day, because that guidance doesn't work for all patients. So really having a patient-centered approach. This is a great guide from Johns Hopkins that's free. Just you can look it up online, called Bouncing Back from COVID by Johns Hopkins. And it's a really nice patient-centered guide to, again, moving your body after COVID infection. What about mental health and cognition? Now, this is huge in COVID. My patient had ongoing anxiety. She was worried about going back to the grocery store. She was worried about getting reinfected or infecting others. And so studies are showing that these cognitive symptoms are not in people's heads. They are real. They're very common. About 1 in 5 patients report them. And there's so many mechanisms. This is where the research questions come into play. Is it because of undiagnosed hypotension, hypoxia, micro and macrovascular thrombosis? Is it related to autoimmunity, maladaptive cytokines? Every single one of these hypotheses has been studied and found to be true. Again, that's the tricky thing about this type of research, is that there's so many different mechanisms at play, and we don't know exactly which mechanism is underlying which patient's symptoms, and which patients might have multiple mechanisms. So again, a simple one size fits all is likely not going to be able to help, but all of these are active areas of research. There's research studies about all of these going on. And some patients have a lot of cerebrovascular symptoms like strokes, and some patients have a lot of neuropsych symptoms. So new onset psychosis, in addition to, of course, depression, anxiety, PTSD being quite severe. And again, from the pre-COVID literature, we know that depression, cognitive impairment, and physical function limitations and disability can all be a vicious cycle where they're very intertwined. And that can persist also for months. So PICS is post-intensive care syndrome. And many patients who are recovering from intensive care syndrome have this vicious triad of depression, cognitive impairment, and physical function limitations that persist. And we're seeing the same thing in COVID. So this basically is a great article from Lancet Respiratory Medicine that just shows that these same symptoms that we saw with mental health and physical health impairments are being seen both before COVID and after COVID. And as we know, our hospitals are not friendly places to be, even in the best of times. But in COVID times, it is a delirium factory. That's what leading delirium researcher, Dr. Wes Ely, says. This is an article in the New York Times about one of our patients at UCSF, and he talks about the terrifying nightmares and hallucinations that he had while hospitalized with COVID in our ICU. And so we do a lot of attention to mental health. We talk to patients about their mental health. We give them coping strategies. We connect them to peer support, including virtual peer support. And we see, do they actually need a psychiatrist? As I'll talk about, psychiatry is in high demand in the pandemic. We do not have funding for a psychiatrist, unfortunately. I wish we could. So we try to do some basic screening and see who needs a formal psychiatry referral and who needs a little bit of counseling and therapy from perhaps a mental health social worker. We also talk a lot about loneliness and safe socialization, especially again for our elderly population. If you have one resource that you want to read as a primary care provider after this talk, I would recommend you look up this oldie but goodie from the BMJ in 2020 by Dr. Trish Greenhall and colleagues. And it's this 2-page infographic for PCPs on long COVID. And she talks about, basic blood tests to order, to be mindful of comorbidities, be mindful of social, financial, and cultural support, and think about what patients can do in terms of self-management too. A daily pulse ox for some patients can be very reassuring to help them have more physical activity. Pacing, again, as tolerated, pace and rest. Relax, avoid alcohol, smoking, and good sleep, things like that, and when to consult. So this is a great resource. What about clinics like ours? Are they effective? Are they cost effective? What goes into a clinic like that? Is it just hype or does it actually help? And, to share a little bit about our clinic's experience, our clinic is rooted in this model of PICS, post-intensive care syndrome, not because all of our patients were in the ICU, but because PICS is a framework that says you have to ask holistically about mental health, physical health, cognitive function, and pulmonary function, just like I outlined in this talk. And you have to pay attention to the caregivers and the patients. So that's what PICS says. And you'll see here in this graphic, many of the symptoms of PICS are very, eerily similar to long COVID. Fatigue, memory loss, brain fog, depression, anxiety, PTSD, all of these symptoms we've seen in PICS and now we're seeing in long COVID. So again, not all patients with long COVID have been hospitalized, but we can take lessons from the PICS literature and PICS treatment and apply them to our patients. And again, if there's another thing to take away from this talk, it's to just ask systematically about these 4 domains: pulmonary, physical, cognitive, and mental health. That's what we do in our clinic. So in our clinic, we started in May 2020. We have pulmonary, we collaborate with geriatrics, pharmacy, physical therapy. We have a mental health social worker. And the key that I would impart is that we have faculty champions in other divisions. We can't do it all, right? We can't, it's not cost effective to hire a cardiologist and a neurologist, et cetera. So what we found is, who is the cardiologist in your community who's actually doing good consults for these patients and wants to see these patients? What about the neurologist, et cetera? We try to collaborate very closely with existing research at UCSF. So I'm not a researcher, I'm a clinician. But I want to connect my patients to any research opportunities that are available in the Bay Area. So for our after visit summary, the whole first page is basically a list of studies to say, hey, if you have COVID and have cancer, try this study. If you have COVID and had cardiac symptoms, try this study. If you have COVID and you were hospitalized, try this study, et cetera. So we try to collaborate closely with the research folks. And because our resources are limited, we currently are focused on patients who are admitted to the hospital because our team is so small, as you see here, and we have limited capacity, though we'd love to expand. So what we do is that if people are hospitalized, we see them in our clinic. If people were not hospitalized, but they have a lot of pulmonary symptoms, we see them in our general pulmonary clinic. And if they're not hospitalized and have no pulmonary symptoms, we try to point their primary care providers into the right direction to say, hey, here's a neurologist that you should be thinking of. Here's a rehab facility that you should be thinking of. So we try to kind of upskill our community and our network. And I do a lot of talks, to community health clinics around the Bay Area to just, again, share this wisdom. Nothing is proprietary. We want to all learn from each other. And so again, we collaborate with others in this hub and spoke model with cardiology, neuro, pulmonary rehab, psychiatry, because it's not cost effective to have one of these specialists sitting in our clinic on Fridays, every single Friday. So what we do is we just find our faculty champions in each division and then send our referrals to them in a streamlined way. And so we have, a mental health assistant, social worker who screens for depression, anxiety. We talk about physical function, breathlessness, social determinants of health. We have a pharmacy colleague who looks at the med rec to see, can we de-prescribe? And we link people to resources like virtual pulmonary rehab, support groups, and things like that. We've seen over 400 patients so far, and we're a member of the Cairo group, which is a national group of long COVID clinics, just so that we can learn what others are doing. And we talked about, and gave very nitty gritty advice, including Epic EHR templates, if you want to go and take a look at that for your own clinic, about how to start a post-COVID clinic. So check out this article, which includes links to our Epic note templates and things like that. But what's frustrating is asking for funding. So I was so frustrated with this that I wrote this article that was more of a perspective piece about building the business case for a post-COVID clinic. So we operated as a truly volunteer shoestring effort for about 2 years before we were able to get formal UCSF funding for the physical therapist and social worker, et cetera. And so how do you make a business case for this? What we argued was that we're finding complications early, we're preventing readmissions, we're preventing hospitalizations, and we're also kind of consolidating care. So a patient doesn't go to the ER 10 times in a row for chest pain if they get some education about long COVID and we find some ways to manage their chest pain a bit better. So, do I have data showing that we're cost effective? Not yet. That's coming. I haven't seen any other clinics showing that data either. It does require investment up front. And so the problem is very few people can generate RVUs, right? Only the pulmonary docs or maybe the psychiatry docs, if you have those, can actually bill for a visit. But paying for a social worker costs money, paying for a physical therapist, a pharm tech, a practice coordinator, all of that costs money. So a lot of it is negotiating to say, hey, with these upfront costs, we might be able to save you money down the line by consolidating care at UCSF in our clinic, preventing readmissions, et cetera. And again, collaborate, centralize referrals, and find champions. So if you're thinking this is not possible where I'm at, we don't have any of those resources, think about at least collaborating with other centers, centralizing referrals, say, who is your point person? Who is your champion in your center? And what about research resources at UCSF and beyond? So the biggest resource that I would point you to is the LINK study. If you look up the LINK study, there's a really broad leadership team, including community partnerships, chaired by Dr. Peluso and Dr. Deeks and Dr. Rodriguez. And they talk about, linking patients. They don't have to be hospitalized. And they do a lot of looking into patients' blood samples, functional testing, et cetera. And they recently received new funding from NIH as part of the RECOVER trial to actually even start hopefully testing therapies in the coming months to years. And so during our optimal clinic visit, we talked to Miss L, we counseled her about her recovery. We talked about gradual exercise using a home pulse ox. And our mental health support was really valuable to her. And she felt reassured. And we saw her back in 3 months and she looked great. She had her lipstick on and her Sunday best, and she's doing great now, which is wonderful. Again, if I leave you with one last pearl, that's all that long hauls is not COVID. Avoid anchoring bias, keep your differential broad throughout. Remember that list of diagnoses that I shared with you earlier, the sarcoid, metastatic lung cancer, ulcerative colitis, et cetera. Those are all patients that I personally have seen and diagnosed with things that the patient or provider thought it was just long COVID. So keep your thinking cap on, keep your mind broad. And remember, long COVID symptoms can affect multiple organ systems. So multidisciplinary approach is really helpful for the dyspnea, the disability, the fatigue, and the neuropsych symptoms. But there's still a lot of uncertainty that remains. And so ongoing research and community partnerships are really essential for advancing our understanding of this condition. Thank you to my amazing collaborators. These are my kiddos who would wait patiently for me to shower every day when I came back from the COVID ICU before giving me a hug. And thank you all for listening. I'm happy to take questions now, as well as via email, or you can find me on social media. Thank you so much.
Thank you. Thank you so much, Dr. Santhosh. I think that was a really information-filled talk, and I just want everyone to know that it's being recorded, and so if you feel like you missed something, there will be an opportunity for everyone to listen to that. And I think what the conversation will be focused on here is I think we'd love to hear a little bit about what other people's experiences are treating long COVID in their communities. In addition to any particular questions you might have for Dr. Santhosh. And if you can put your questions in the Q&A section, we'll try to allow you maybe to even ask your question for yourself, but please at least, I don't know, Saji, if you can make it possible for us to see everyone or for people to raise their hands from here, but at least if you do have questions, put it in the Q&A section. While Saji's trying to figure that out on his end, I'm going to open the floor first to Dr. Guerra Sanchez and ask you for some reflections on what's going on with long COVID in your experience in the Family Healthcare Network in the Central Valley, and any questions that you might have for Dr. Santhosh.
Thank you, Michael. I want to make sure that everybody can hear me. Thank you, Dr. Santhosh, for that great talk. I'm a little bit interested, with me being in the Central Valley, our access to specialty care is a little bit more complicated. And so I was very much looking forward to get your perspective on, what are the things that, primary care providers, and we'll share the BMJ resource with everybody. But, what are the things that you think a primary care provider can start doing for their patients that should, constitute, basic care? You talked about, doing, starting kind of like doing an assessment after 3 months, and then kind of like, waiting, to see if some of the patients with certain acute symptoms would recover after that 3-week initial period. And, kind of like waiting a little bit longer to start a workup. And, what would this include? You mentioned the walk test that, you would do in the office. And then the other question that I had, me being a pediatrician, we haven't really had a lot of pediatric patients that have had persistent symptoms to the degree that adults have had. And I know that it's not the, necessarily the patients that you see, but I was curious to see if you had any experience that you wanted to share regarding maybe older school-age kids and adolescents with prolonged and persistent COVID symptoms.
Thank you so much for your thoughtful questions, Dr. Guerra Sanchez, and thank you for all that you do. So absolutely, I hope that many of the things that I shared today I really feel like they're specialty agnostic, right? You don't have to be a pulmonologist, you don't have to be a neurologist to implement some of those things. And that's why I think these pearls are generalizable. I think that first and foremost is just asking about the 4 domains very explicitly and holistically. So physical function, lung function, cognitive health, and mental health. And I think primary cares are way better than pulmonologists at managing most of those things, except for the pulmonary symptoms, right? And for the pulmonary symptoms, I think first that quick assessment with that 6-minute walk of, is this cardiac, pulmonary, or both? One, what about the dysautonomia and deconditioning? For dysautonomia precautions, and I see there's a question in the chat about dysautonomia as well, and POTS and neuropsych symptoms. So for the dysautonomia part, it's quite difficult to manage. So I first start with the basics, like primary care basics. I also practice on the general medicine service too. So my roots are definitely still just in general internal medicine. And so almost like the autonomic precautions you use for your elderly patients with Parkinson's, orthostatic precautions. So compression stockings or compression socks. I've had patients say that they feel a lot better with those. Staying well hydrated with good fluid intake, but not just plain water, actually fluids with some solutes in them, right? That actually it retains your intravascular volume. So I tell people, making sure that you're drinking fluids, but also eating enough calories. A lot of patients lose significant amount of weight with COVID because of fatigue, isolation, for some people, access to food, right? Food insecurity, but also with the loss of taste and smell. So people sometimes have 20, 30 pound weight loss acutely with COVID. And so that loss of muscle mass is a different kind of deconditioning that, again, is all tied up with dyspnea. So dyspnea, deconditioning, and depression are all very much related. And you have to kind of treat all three holistically is how I view it. So just by asking holistically, you can treat each one. If you've identified that, they're acting like an asthma patient or COPD patient, if you're at a place where taking PFTs is going to take forever, there's low harm to starting an as needed, basically as needed asthma treatment. So asthma or COPD treatment, if they're acting like that, if they're acting like a post-viral reactive airway disease. So the latest GINA guidelines for asthma management would suggest a LABA ICS combo like Advair or Symbicort PRN, right? And so I think having just that option for people of an Advair or Wixela or Symbicort PRN for kind of an asthma type syndrome is helpful. Talking them about this graded, very rest, pacing, and exerting yourself, graded exercise activity, things like that. For the neuropsych symptoms, again, what is some of the, Stanford has like a fancy rehab for that. We don't have that, right, at UCSF. And so what do I tell people who don't have access to fancy cognitive rehab? I tell people, do what you enjoyed doing before with your hobbies that keep your brain active. So, reading, keeping in touch, right? Isolation kills your brain cells too. Keeping in touch with your family and friends, avoiding social isolation, crossword puzzles, Sudoku, practicing, all of that stuff. For smell therapy, for people who've lost their sense of smell, you can just basically do exposure therapy where you say, this is a lime, and every day you sniff that lime for 10 minutes, etc. You don't need to have an ENT to do that. So you can tell a lot of patients about these self-management strategies at home. For your second question about pediatrics, I always say that unlike many experts in the COVID pandemic, I don't speak outside of my specialty. I don't speak outside of my expertise. I'm very cognizant of the boundaries of my expertise. So I don't have experience treating pediatrics, but I will point you to Dr. Ted Ruel, R-U-E-L, who's at UCSF Children's, who kind of takes care of a lot of long COVID patients there. I absolutely agree that it's been less reported. There's, of course, the acute COVID in children, which is devastating, can be devastating. The MISC, right, the multi-inflammatory system syndrome that you have to watch out for, that's quite fulminant and devastating. But then some pediatric patients, particularly teens, can have a lot of these long haul symptoms similar to adults. And so similar treatment strategies, I think, are going to become useful.
Great. I guess people are not putting questions in the Q&A. So if that seems to be difficult, just put them into the chat and make sure that everyone can see them. I know that this is a little bit of a mixed audience, so I'm going to guess that some of the acronyms and rapid fire information that we're hearing may be a little bit hard for some of you to decipher, but I'd love to step back just a little bit and talk about more about the logistics of delivering this type of care in community-based settings, especially in community health centers. And I'm wondering, both you and both Lekshmi and Carlos, what you see as the opportunities for clinical collaboration between UCSF and the Bay Area's community health centers with regard to delivering community services and supporting primary care teams to deliver care for these patients, as well as opportunities potentially for research questions that you would like to see answered. And I'll let both of you reply individually. Maybe Lekshmi, you can go first.
Absolutely. I just put in the chat, this website about the UCSF Center for Community Engagement. And I think that website is a great portal for thinking about opportunities to get involved from a research perspective, from a clinical perspective, from a community service perspective, with the vast COVID network at UCSF. And so I definitely encourage you all to check that out as well. I think I think that community health centers and community partnerships are absolutely imperative. I think that we know again that this pandemic has particularly affected people of color disproportionately because of, as I mentioned earlier, our socio-political environment that we live in addition to racism and classism and barriers to access to care throughout. So this is a pandemic that's disproportionately affected patients of color. And so we absolutely need to empower our clinicians all over California and all over the country and all over the world to take a very proactive and deliberate approach to combating those disparities throughout and to collaborate. And so, like I mentioned, I'm not a researcher, but the UCSF Research Network is absolutely interested in partnership with community networks to get collaborate with data, pool data, think about how we can be helpful. So Dr. Puliso and Dr. Deeks of the UCSF Link study have a lot of opportunities. We want patients, to join these trials so that we can learn about the underlying biology and hopefully to test out treatments really soon, because in this vacuum, there's a lot of, snake oil salesmen and women out there preying on fears of patients and saying, here's a non-evidence-based IV vitamin C that's going to cure everything, and it's not. And so, and I think, of course, vaccination is one thing that I think is also imperative. I didn't show a slide on this, but There's some data that suggests that the vaccine can decrease your long COVID symptoms too in some patients. And so telling patients that it's not too late to get vaccinated, removing the shame and stigma around vaccination, around COVID infection. And, our booster rates in America are so much lower than other countries with a national healthcare system, a universal healthcare system. And we're going to just be breeding more and more variants if we have a significant patient population that hasn't yet had the vaccine, hasn't yet been boosted, and things like that. So I think absolutely we need to partner from a clinical perspective, from a vaccine rollout perspective, from a research perspective, all with that equity lens in mind.
Right. And before I let you answer, Carlos, I'll just mention that through our CTSI community engagement program, we do have we've had a service for researchers to receive community input on their research programs related to COVID-19 specifically. And you're welcome to anyone who's listening, who's interested in engaging with community stakeholders to develop these projects, is welcome to email me. And we can set up a consultation for you. Throughout the dozens of research programs have been facilitated through this, the use of this community advisory board, and it does really, really help. Carlos, I'm wondering what your thoughts are about opportunities for partnerships. And I know there's actually a lot of great work that's been going on at UCSF in Fresno, and I know with your organization. So I'd be curious to hear what your thoughts are about that as well.
Yes, so I had a little bit of a comment on the issue, and then I actually was going to ask Dr. Santhosh another question if she had the time for it.
Absolutely.
I think one of the things that I would say we have noticed, and I'm not a practicing internist, so this is somewhat of a experience from the providers that I work with, is that I think that a lot of patients with certain constitutional symptoms and certain neurological symptoms are managed by the primary care providers. And then the patients who have had prolonged hospitalizations, ICU stay, who had deconditioning and who've had pulmonary fibrosis are probably the patients that end up seeing a specialist, right? That end up seeing a pulmonary physician, or maybe the patients that have like POTS, end up seeing a specialist as well. But I think that a lot of the patients that have just very prolonged fatigue and deconditioning and poor exercise tolerance and some psychiatric symptoms, some cognitive symptoms, poor sleep, insomnia, right? Depression. Those are the patients that are actually seen, but for the most part, by the primary care providers. And a lot of these patients end up having some sort of partial disability as a result of these symptoms, right? And so I think, there's a subset of patients that, time, will, improve some of their symptoms, but there's some of them that will have very prolonged symptoms, regardless of whether they had a severe COVID illness or not. And so I think for primary care providers, having some access to whether it would be like a virtual consultation or an e-consult of some kind, I think can be of value, because like you said, I think there's a lot of strategies that even if you don't have necessarily a physical therapist, even if you don't have necessarily, a psychiatrist available, right? For patients that are not severely disabled, there might be an opportunity for the primary care provider to use that toolbox with some guidance, right? And so I think that is something that across the board, it would be beneficial for the majority of patients to have everybody have a certain, basic fund of knowledge on how to manage these conditions. I think it quickly is becoming a staple of primary care. And again, what you mentioned as well, as to keeping a broad differential is very important. I think a lot of people, forget about it. And like you said, a lot of patients, we have seen it time and time again, have not had primary care in the last 2 years. And, I ran into that situation myself. The providers that I work with run into that situation very commonly. And so, sometimes, unfortunately, that, post-COVID visit ends up being their entry back to primary care. And so, making sure that you have the differential, that you not just like put everything under the same bucket. I think it's important, right? When at some point you need to, kind of like go back to like the drawing board and making sure that you are doing some basic labs and maybe some imaging and maybe some PFTs. Some things are definitely, even in a place with not a significant access to a specialist, there are certain things that can be done by the primary care provider. So I think that's important, just building that knowledge. And touching on the topic of treatment, I know that there's an area where there's a lot of research going on. I think there's maybe not as many answers as we have had for the treatment of acute COVID, in which I think there has been a lot of progress made. But for prolonged symptoms or long COVID, I think there's a little bit more uncertainties right now than answers. But I was wondering if you can talk a little bit about the data that is available for vaccination as management of patients that actually have had recovered for COVID and have prolonged symptoms. Because my understanding is that there's observational data. I don't think there's an RCT, to my knowledge, that has been completed and published about it. But maybe you can talk a little bit about, what information, is available, because I think that is also another very helpful tool for clinicians to try to endorse vaccination of their patients that have not been vaccinated or boosted yet, right? If you have had COVID and you have this prolonged illness, these are some things that have been tried and has been shown to help some patients in certain situations.
Such a great question.
Such thoughtful comments, Dr. Guerra Sanchez, and thank you so much for bringing that up. And I think you're exactly right that in primary care, you are all at the front line of this huge outpatient now pandemic, right? And every inpatient surge is followed by this huge outpatient surge with numbers that are vastly higher than what the inpatient side is seeing. And a lot of it is falling on already busy primary care practices who don't have extra funding or access to specialty care. So again, I am in such awe of all primary care practitioners and think that our country needs to do more to support primary care. The number of burdens is just unreasonably high. I love what you said about capacity building and about, virtual consultations. I've worked with a lot of practices to give them, just like quick advice or consults about how to build a center of excellence just like this. Again, I don't have any consulting fee or anything like that. So feel free. I'm happy to help any of you all and point you in the right direction. And I agree that there's a lot, like I said, that's specialty agnostic that you can do with a little bit of knowledge. So please, all of you who are listening in, take this knowledge that you learned today and spread the word and share the pearls that you've learned today. And again, that's how we're going to enrich and capacity build all of our collective knowledge base as we're all still learning and treating this condition. To your point about vaccination, so you're exactly correct that I find the talk about vaccination, I see people who are in the ICU on death's door and who still haven't gotten the vaccine yet because of, again, lots of different barriers and to not wanting that. And so the vaccine as a tool for long COVID symptoms is just another kind of arrow in my arsenal of motivational interviewing tips and tricks and techniques that I use. It's another strategy, just as you said. So the best paper for this is in Annals, which showed that, again, and it's not perfect, right? It's not a cure, but showed that a significant minority of patients did have symptoms improve, and in some cases even resolve with vaccination. Most people stayed the same, and a very tiny population had worse long COVID symptoms. So it's not a cure, it's not a cure-all. But for that patient that I'm doing that motivational interviewing counseling, I say, hey, we've had a lot of different studies come out about vaccination. And for many patients, and I've seen it personally, their symptoms got better with the vaccine. For Paxlovid, like I mentioned, it's a mixed bag. And again, ongoing trials, that question would not recommend off-label Paxlovid prescriptions for long COVID, because again, it gets back to what is driving these symptoms. For some people, it may be viral persistence. For some people, it may be autoimmunities. For some people, it's inflammation. For some people, it's cytokine response. And so there can be harms. Paxlovid has a lot of drug-drug interactions, as you know. And so we just have to be mindful to wait for the actual studies to come out on that. But vaccination, definitely multiple studies showing that it can only help in a small percentage of patients, only it made it worse. Of course, everyone feels terrible the first day. Counseling people that that's normal, right? Counseling people that shows that your body is fighting it, your immune system is fighting it, and coaching people through it. But that's one thing that we can offer. And for now, I think back to that CDC slide that I showed earlier, ask your patient, which of these symptoms is the most bothersome to you, right? Just like you're doing in primary care all the time, you're triaging all the time. And so say, okay, dysautonomia is the worst or brain fog is the worst. Let's work on strategies for that on this visit. Brain fog is the worst. Let's try these cognitive exercises. Deconditioning fatigue is the worst. Let's try this. So trying a symptom-driven approach can be really, really helpful. And again, in primary care, that's what all of your training and care delivery is about. That is symptom management and triage.
So we're coming up to the end of our hour, but I just want to thank you all. We do have, there's one attendee that wanted to say something. The main thing I wanted to say is number one, thank you. And number two, I'm hearing about some possible priorities or things that we could work on. One is resources for community-based health systems and providers to be able to address COVID-19 lung symptoms in their own primary care settings. So there probably are some opportunities for not just for sharing clinical pearls, but actually to study different approaches. And I think this other issue of, that Carlos brought up that I think is really interesting is for people who have had COVID but have not been vaccinated, and who may have symptoms, is that an opportunity to provide vaccine, and can that actually improve symptoms? And what can we tell them? What are the messages that would work for that? So I think those are some really great opportunities, and we will be continuing to have more of these webinars. We're planning a webinar in June, so that will be on the issues faced in children and adolescents with mental health and the after effects of COVID, and what we can do to help those patients and their families in primary care. And then finally, we'll also be having a meeting in September 30th, where we'll be having an in-person meeting, which will be all day, in which we will address a lot of different issues, but COVID will be one of them. And we hope some of you will decide to attend that as well. It's open to everyone, to the public. So keep posted, and thank you very much. And I see that there may be one or two additional questions. If there are questions that haven't been answered, that you didn't get a chance to answer, please send them to me and Saji, and we'll try to do our best to get them answered. And unfortunately, because we're at the very end, I think I'm not going to be able to allow anyone who wanted to speak to do that, but I think there was just one or two of you. So thank you so much. I learned a lot, and I hope you did too. And please answer your survey as you log off. There will be an opportunity for you to provide feedback and additional questions that we'll try to answer. Take care. Bye.
Thank you. Bye.